I want you to picture a scenario. It's one of those situations that honestly sounds like the start of a bad sitcom, but for this one particular guy, it was a very real clinical vignette.
Oh boy, I think I know the one you mean.
Yeah, you probably do. So meet Daryl. Daryl is a 24-year-old medical student. He's stressed. He is, studying all the time, and he decides he desperately needs a companion.
Study buddy.
Better, a bulldog puppy. He names him Delbert. Now, Daryl absolutely adores this dog. Delbert is just the light of his life. And being a very affectionate dog owner, Daryl develops this habit. He gives Delbert these frequent smooches right on the muzzle, face to face.
And as a microbiologist, I am already cringing so hard at this.
You absolutely should be, because about 3 months into this little love affair, Daryl wakes up and notices his mustache is itching, like really intensely itching. He goes to the mirror, and his upper lip is totally swollen. It's red, it's inflamed, and this is the truly gross part. He starts seeing these little pustules popping up.
Just pus-filled bumps right in the hair follicles.
Exactly, right in his mustache hair.
Which is not a great look for a medical student doing clinical rotations.
Not at all. But here's the real kicker, the plot twist. Daryl looks down at Delbert, the puppy, and realizes Delbert has the exact same thing on his muzzle. Swelling, missing fur, crusty, angry skin.
Ah, the classic mirror image infection. That is textbook.
Right. So Daryl, being a responsible dog owner, takes the puppy to the vet first. The vet puts Delbert up on the examination table, takes one look at the dog's face, then looks up at Daryl's lip and just immediately steps back.
That is a very smart veterinarian.
Extremely smart. The vet writes a prescription for the dog and says very firmly, I can treat Delbert, but I absolutely cannot treat you. You need to go see a dermatologist, and you need to go today.
This is such a perfect vignette to start our deep dive with because it really highlights the boundaries of clinical medicine, but much more importantly, it introduces us directly to the world of zoophilic dermatophytosis.
Which is exactly what our mission is for today. We are diving deep into Murray's medical microbiology, specifically focusing on Chapter 62.
And we're bringing in some highly relevant supplementary material from Chapter 45 of Jowet's just to round out the clinical picture.
Exactly. We are navigating the whole landscape of fungal infections that live on the surface of the human body. Because usually when we talk about infectious diseases on this deep dive, we're talking about things getting inside you.
Right, invading the blood, the lungs, the deep organs, systemic threats.
But today, we are talking about the fortress itself, the skin, and the fungi that have figured out how to live on the walls of that fortress without necessarily breaching the inner castle keep.
I really like that image, the castle wall. And to really master this chapter, especially if you're studying for boards, you absolutely need to divide this fungal world into 2 very distinct layers.
If you walk away with one mental framework today, let it be this split. We have the superficial mycoses, and we have the cutaneous mycoses. Now, they sound similar. Superficial, cutaneous, and everyday English, those are basically synonyms, right? Just meaning on the skin.
In everyday English, sure. In medical microbiology, they are night and day. Completely different clinical presentations, different prognosis, different bugs.
Okay, so help me visualize the actual difference using that castle metaphor.
Let's go back to the castle wall. The skin is the wall. The superficial mycoses are your graffiti artists. They sneak up to the wall under the cover of darkness. They spray paint some tags on the absolute outermost bricks, and they just hang out.
They don't damage the wall itself.
Exactly. They do not break the bricks. They don't hurt the structural integrity. They're just sitting there eating the dead organic debris on the surface. And because they aren't causing structural damage, the castle guards, meaning your cell-mediated immune system, they don't even know the fungi are there.
So there's no war.
No war, no inflammation, no pain.
So they're mostly just cosmetic issues. The patient sees the graffiti and doesn't like how it looks.
Precisely. They are the freeloaders. Patients come to the clinic for vanity, essentially.
Okay, so superficial equals graffiti artists. Annoying, but totally harmless. Then what are the cutaneous mycoses?
These are the dermatophytes. And these guys aren't graffiti artists. They are battering rams. They have specialized tools, enzymes that allow them to actually chip away at the bricks themselves. They eat the structure of the wall.
They're invaders.
They are true surface invaders. They penetrate the stratum corneum, they digest the keratin, and because they are actually causing physical damage, the castle guards wake up.
Ah, so the immune system recognizes the structural breach.
That is the key differentiator. The immune system sees the damage, gets angry, and launches a massive counterattack. That is exactly why Daryl's lip was swollen, red, and full of pus. That follicle was a literal war zone between the fungus and his neutrophils.
So superficial equals stealth mode. No pain, no fight, just colonization. Cutaneous equals invasion, tissue destruction, inflammation, and a massive immune fight.
You've got it. And predicting how big that fight will be, how much inflammation the patient is going to experience, is actually one of the most important clinical skills you can develop from this material. But we will build up to that.
Let's start with the stealthy ones. The superficial mycoses. As you said, these live on the absolute outermost layer, the stratum corneum, or just coasting on the hair cuticle.
Right, and stealth is really the operational word here. The patient almost never comes in complaining of physical discomfort. It's usually, hey doc, I have these weird discolored spots on my chest, or my hair has these strange bumps stuck to it.
The most famous one in this category is the one I feel like every medical student learns first, and frankly, anyone who spends time at the beach has probably seen, is pityriasis versicolor. Or you might hear it called tinea versicolor.
Yes. If you spend any significant time in warm, humid climates, you have absolutely seen this condition in the wild.
So what is the actual creature behind these spots?
It is a yeast called Malassezia, specifically the Malassezia complex. There are a few different species involved, primarily Malassezia furfur, Malassezia globosa, and Malassezia sympodialis.
Now, going through the textbook notes, Malassezia is described as having a very, very specific dietary restriction. It's basically a foodie.
It is a total foodie. These yeasts are strictly lipophilic.
Meaning lipo for fat, philic for loving. They love fat.
They absolutely require it to survive. Biologically, they have lost the metabolic ability to synthesize their own long-chain fatty acids. Most microorganisms can synthesize their own fat to build their cell membranes. Malassezia cannot. It has to steal it from the external environment.
And where on the outside of the human body do you find a readily available buffet of free fat?
In sebum, the oil that our sebaceous glands produce. That is exactly why you typically find this specific infection localized to the greasy parts of the body. The upper chest, the back, the shoulders, the upper arms, areas incredibly rich in sebaceous glands. The fungus is literally just sitting there at the sebum buffet.
This leads to a really fantastic board-style detail about how you actually diagnose this in the lab. Because if you just scrape some of that skin off and put it on a standard agar petri dish, absolutely nothing happens.
Correct. And historically, this used to confuse laboratory technicians all the time. They would clearly see the fungal elements under the microscope from the patient's skin, but the culture plate would remain completely barren. The fungus was starving to death on standard media.
So what do you have to do to make it grow?
You have to cater to its specific diet. You literally have to take a bottle of sterile olive oil and drizzle it over the top of the culture plate.
You're making a little salad dressing for the fungus.
Basically, you overlay the culture medium with olive oil to simulate the fatty, lipid-rich environment of human skin. If you do that, the Malassezia grows happily. It is a fantastic diagnostic anchor to commit to memory. If a board question mentions adding olive oil or long-chain fatty acids to a culture, the answer is definitively Malassezia.
I love that anchor. So we have this fat-loving yeast hanging out on my back, eating my natural skin oil. But why do we call the disease versicolor?
Well, versicolor translates to changing colors. And this is the fascinating paradox of the condition. It presents completely differently depending on the patient's baseline skin tone.
How so? Explain that visual.
If you have dark skin, the infected patches usually look hypopigmented, meaning they are significantly lighter than your normal skin tone. But if you have very pale skin, those exact same spots might look hyperpigmented. They show up as pink or light brown patches.
But why the color change at all? If it's just a graffiti artist sitting on top of the wall eating oil, why is it messing with my actual skin pigmentation?
That is the stealth mechanism interfering with your underlying biology. The fungus is metabolically active, and it produces byproducts, specifically dicarboxylic acids like azelaic acid. These acids diffuse down from the stratum corneum into the deeper epidermis and actively inhibit an enzyme called tyrosinase.
Tyrosinase, that's the key enzyme in the pathway that makes melanin, right?
Exactly. So the fungus is chemically turning off the melanin pigment factory in the melanocytes directly below it. It acts almost like a localized chemical sunscreen.
So that perfectly explains the classic clinical patient story.
Mm-hmm.
They go on a tropical beach vacation, they get plenty of sun, they tan everywhere else on their body, but the fungus spots stay pale because the melanin factory is shut down in those specific areas.
Right. And that contrast is usually the exact moment they notice it. They come into the clinic saying, "Hey, doc, I look like a leopard."
So the patient comes in with leopard spots on their back. How do we definitively confirm it? We have to talk about the microscopic exam classic, because this is probably the most famous food analogy in all of medical microbiology.
It absolutely is. You do a simple KOH prep. That means you scrape the scaly skin, put it on a glass slide, and add potassium hydroxide. The KOH dissolves the human skin cells in the keratin, but leaves the tough chitin fungal walls intact so you can see them. And what you see under the microscope is a very specific mixture of spherical yeast cells and short, thick, curved hyphae.
And together they look exactly like
Spaghetti and meatballs.
It's such a visceral image. The spherical yeast clusters are the meatballs, and the short hyphae are the strands of spaghetti.
It is a visual anchor that you will never forget once you see it. You see spaghetti and meatballs on a pathology slide, and you are 100% sure you were dealing with pityriasis versicolor.
Now, before we move away from Malassezia entirely, I was looking at the notes from the Jawed supplement. It's not just about the cosmetic spots in the back. It's also the culprit behind something much, much more common in the general population. Dandruff.
Yes, specifically seborrhoeic dermatitis. That flaky, itchy scalp condition, or that persistent redness and flaking you get in the eyebrows or right in the creases around the nose, that is very often an inflammatory reaction to the Malassezia living in the sebum of those areas.
And that's why anti-dandruff shampoos, things like Head & Shoulders or Selsun Blue, why they work, they often contain topical antifungals or selenium sulfide, specifically designed to knock down the local Malassezia population.
That makes perfect biological sense. But Javed's also highlights a much darker, much more dangerous side to this lipid-loving trait, something that happens specifically in hospital settings.
This is a really critical connect-the-dots scenario for students.
Yeah.
We established that Malassezia strictly requires lipids to survive, right?
Right.
Well, think about the neonatal intensive care unit, the NICU. Premature infants very often need their nutrition delivered intravenously. We call it TPN, total parenteral nutrition. And a massive component of TPN is lipid infusions, liquid fats.
Oh, I see exactly where this mechanism is going.
If that central venous catheter becomes colonized by Malassezia from the skin of the baby or a healthcare worker, the fungus doesn't just sit on the skin anymore. It literally tracks up the outside of the catheter and into the lipid mixture. It treats the IV line like an all-you-can-eat fat buffet.
And then that colonized lipid mixture gets pumped directly into the baby's systemic circulation.
Exactly. It causes a profound fungemia fungus actively replicating in the bloodstream. It can be deadly, and it happens specifically because the organism is lipophilic, and we are inadvertently feeding it pure lipids through the IV.
That is an incredibly terrifying thought. So normally it's just a harmless skin graffiti artist, a cosmetic nuisance, but give it a direct highway of olive oil into the bloodstream, and it becomes a lethal pathogen.
Context is absolutely everything in microbiology.
It really is. All right, let's keep moving down the list of the superficial mycoses. We have something next that sounds visually terrifying to a patient, but keeping with our running theme, is actually functionally harmless. Tinea nigra.
Tinea nigra. This one is the great pretender of the dermatology clinic.
The causative agent here is a fungus called Hortea vernecki. Where geographically are we usually finding this organism?
It's mostly found in tropical or subtropical regions. Central America, South America, parts of Africa, sometimes the southern U.S. It's very often associated with coastal areas and salty environments.
And the clinical presentation, frankly, if I woke up and saw this on my own hand, I would probably have a full-blown panic attack.
You would definitely not be alone in that reaction. It typically presents as a solitary, totally irregular brown or black patch, a macule, and it is almost exclusively found on the thick skin of the palm of the hand or the sole of the foot.
An irregular black spreading patch on the palm. To any medical professional, that looks exactly like
malignant melanoma.
Oh.
Acral intertriginous melanoma, to be highly specific. That is the exact same kind of aggressive skin cancer that Bob Marley passed away from.
That is the scare factor. You see that dark spot and your clinical mind immediately jumps to the absolute worst case scenario. Cancer.
And this is exactly where understanding the superficial classification completely saves the day. Because unlike melanoma, which is a deeply invasive cancer that metastasizes, Tinea nigra is literally just a fungus sitting on the very top layer of the dead stratum corneum. It is completely 100% non-invasive.
But why is it black? Is it causing local bleeding or bruising in the skin?
No, not at all. The fungus itself is what we call dematiaceous. That means the organism naturally produces melanin-like pigments in its own cell walls. The graffiti it sprays is literally black paint.
So how do you practically tell the difference in the clinic without slicing a huge chunk of someone's hand out? I imagine you really don't want to perform a deep excisional biopsy on the palm of a hand if you don't strictly have to. The morbidity there is high.
Exactly. You do a simple, non-invasive skin scraping, another KOH prep. It takes 5 minutes in the office. If it is tinea nigra, you will clearly see pigmented, dark brown, septate hyphae and budding yeast cells under the microscope.
And if you see those brown hyphae,
You breathe a massive sigh of relief. You tell the patient the good news. You prescribe a topical dandruff shampoo or a basic over-the-counter antifungal cream, and the spot literally washes off over a few weeks. You save the patient from a highly traumatic surgical excision and weeks of agonizing anxiety waiting for a pathology report.
that is a huge, huge win for the simple light microscope. So Hortea wernickeyi is your classic melanoma mimic.
Correct. Hortea wernickeyi on the palm equals tinea nigra.
Excellent. Next up, in our freeloaders category, we have the piedras. These are strictly hair infections.
Right. And the word piedra literally translates to stone in Spanish. And that is exactly what these clinical presentations look like. Little hard stones or nodules physically attached to the hair shaft itself.
We divide these into white piedra and black piedra. Let's distinguish them carefully because they're caused by very different organisms and have different microscopic rules.
Let's start with white piedra. This one is caused by Trichophyton species. These are yeast-like fungi.
What do the actual stones look like clinically?
They are soft, pasty, white or light brown swellings. They aren't actually hard like a rock. They form this soft sleeve that wraps entirely around the hair shaft. You typically find this infection in the groin, on pubic hair, in the axilla or armpit, or sometimes in the facial beard.
Gross. Soft, pasty fungal nodules in the beard hair.
It is definitely not pleasant. It's often associated with poor personal hygiene, but there is a very specific laboratory warning for Trichosporon that medical students absolutely need to know for exams.
Yes, the cyclohexamide issue. We need to explain this.
Right. Standard fungal culture, media like Sabarod agar, usually contains an additive called cyclohexamide. It is an antibiotic agent that intentionally kills off rapid-growing environmental molds and regular bacteria so that the slow-growing pathogenic dermatophytes have time and space to thrive. But Trichosporon is a very wimpy organism. It is completely inhibited by cyclohexamide.
So if you just blindly send a hair sample to the lab and write fungal culture on the requisition, and they use their standard default plate,
It won't grow at all. It will be
Right.
killed. You will get a false negative report back and the patient stays infected. You have to explicitly communicate with the lab and write, I clinically suspect white piedra. Please do not use cyclohexamide in the media.
that is a brilliant pro tip for practice. Now, what about black piedra?
Black piedra is caused by an organism called Pityria hortae. Now, this one is a true mold, not a yeast-like organism. And true to its name, it forms incredibly hard, black, gritty nodules,
Like actual miniature stones.
like literal cement. If you run your fingers through the patient's infected hair, it feels like sand or grit is permanently glued to the shaft. And you usually find this one on scalp hair, unlike white piedra.
And biologically, if you look at this nodule under a microscope, it is structurally fascinating. It's not just a random clump of fungal hyphae, is it?
No, this is the part that kind of blows my mind from a biological perspective. The hard black nodule is actually the sexual reproductive phase of the fungus. It forms a structure called an ascostroma. And deep inside that hard black cement casing, there are these little sacs called asci, and those sacs are packed full of sexual ascospores.
So the patient is literally walking around with a hardened fungal reproductive colony cemented to the hairs on their head.
A sexual fruiting body, yes.
Nature is wonderfully disgusting sometimes. And what is the standard medical treatment for both of these piedra infections?
Honestly, a haircut.
Just shave it all off?
The fungus is entirely localized to the external hair shaft. It doesn't invade the follicle down into the skin. Shaving the infected hair is the definitive curative treatment of choice. It physically removes the entire organism. You can try to use topical antifungals, but the razor is vastly faster and 100% effective.
Simple enough, so that elegantly wraps up the superficial mycoses. The castle wall is painted with spaghetti and meatballs, maybe a few fake melanoma spots on the palms, or some gritty reproductive stones glued to the hair, but the skin wall itself stands completely firm.
Exactly. No tissue invasion, no immune inflammation, no physical pain.
Now we turn the corner. We are moving into section 2 of Murray's chapter, the cutaneous mycosis, the The
The
dermatophytes,
true invaders.
the battering rams. This is where we circle all the way back to Daryl and Delbert the puppy. Inflammation, pus, tissue destruction.
Right. And before we get into the bugs themselves, we have to clear up a massive linguistic mess that confuses patients all the time. Ringworm.
It is not a worm.
It is categorically not a worm. It never was a worm. It is a fungus. But because the resulting skin rash very often expands in a perfect circle with a clearing healing center, it looks to the naked eye like a red, coiled worm burrowing under the skin, hence the historical name ringworm. But scientifically and clinically, we call these organisms dermatophytes.
And there are three kings of the dermatophytes. Three specific fungal genera that we absolutely need to know inside and out.
Yes, if you learn absolutely nothing else about the naming conventions today, memorize these three genera: Microsporum, Trichophyton, and Epidermophyton.
How do we initially differentiate them? I mean, clinically speaking, do they prefer to attack different parts of the body?
They do, and creating a mental matrix of this is a fantastic way to classify them for exams. Let's start with Microsporum. Microsporum infects the hair and the skin. It rarely, if ever, touches the nails. Then we have Epidermophyton. Epidermophyton infects the skin and the nails, but it completely spares the hair. And finally, we have Trichophyton. This is the absolute triple threat of the fungal world. It readily infects the hair, the skin, and the nails.
Okay, that is a perfectly clean matrix. Trichophyton does it all. Microsporum does hair and skin. Epidermophyton does skin and nails.
Exactly.
Now, let's talk about their primary weapon. You called them battering rams earlier. What specific biochemical tool allows them to break through the skin barrier when the superficial graffiti artists couldn't even make a dent?
Their battering rams are a class of enzymes called keratinases. These dermatophyte fungi are strongly keratinophilic, meaning they love keratin, and they are keratinolytic, meaning they possess the enzymes to actually digest and break it down.
And keratin is the primary structural protein that makes up our outer skin, our hair, and our nails. It is incredibly tough stuff. I mean, structurally, it's basically organic plastic.
It is remarkably tough. It's highly waterproof. It's chemically resistant to most degradation. Most microbes simply cannot eat it. It would be like a human trying to eat and digest a leather boot.
But dermatophytes have evolved to do exactly that. They secrete these keratinases to literally bore their way down into the tough stratum corneum and burrow deeply into the hair follicles. But they do have a strict biological limit, right?
Yeah.
You mentioned earlier that even these aggressive invaders don't usually cross into the bloodstream or invade the deep visceral organs. Why do they suddenly stop at the deeper layers of the epidermis?
This is a beautiful example of an evolutionary trade-off. They have completely mastered the biochemical art of eating complex keratin, but they have paid a steep biological price to do so. They are highly thermointolerant.
They literally cannot handle the heat.
Specifically, their enzymatic machinery struggles to survive and replicate at 37 degrees Celsius, which is our internal core body temperature. They vastly prefer the slightly cooler ambient temperatures found strictly on the skin surface, which usually hovers around 34 to 35 degrees.
So the inner fortress wall holds primarily because the inner sanctum is just physically too hot for the invaders to survive.
Exactly. And combined with that, there are also specific factors present in human blood serum, like the iron-binding protein transferrin, that actively inhibit their growth. So they are biologically locked into the cooler avascular outer layers of the body.
Yeah.
Unless the patient is profoundly immunocompromised, these fungi literally burn up and die if they try to push deeper into the dermis.
That is fascinating. It's like they are highly specialized polar explorers, suited only for the Arctic Circle of the body, and moving toward the equator instantly kills them.
That is a really great analogy.
Okay, now we are moving to what the textbook outline explicitly calls the single most important conceptual framework in this entire chapter. This is section 3, the ecological classification of dermatophytes.
This is the absolute key to everything clinical. If you are a doctor looking at a scaly rash on a patient, understanding this concept tells you the prognosis instantly. It tells you how long the rash will last, how angry it will get, and how easy it will be to cure. It is the host-guest mental model.
We classify these specific fungi based on where they naturally normally live, not just where we swab them from, but where they spent thousands of years evolving.
Correct. We divide them into 3 primary ecological categories: anthropophilic, zoophilic, and geophilic.
Let's break those down. Start with anthropophilic. Anthro meaning human, philic meaning loving.
These are dermatophytes that have specifically evolved over millennia to live on humans. We are their primary natural reservoir. They are passed entirely from person to person. Classic examples here are Trichophyton rubrum or Trichophyton tonsurans.
So they are completely used to our biology.
And they are what we call the polite guests. Think about it purely from an evolutionary standpoint. A successful parasite really doesn't want to kill its host or trigger an alarm that gets it kicked out. It wants to quietly stay, feed, and reproduce. So, anthropophilic fungi have evolved sophisticated ways to fly under the radar of our cell-mediated immune system. They cause very mild, low-grade inflammation.
To a patient, that sounds like a good thing, right? Mild inflammation means it doesn't hurt much.
Paradoxically, it is terrible for the actual cure rate. Because the host's immune system isn't heavily triggered, it doesn't mount a strong counterattack. It basically ignores the guest. So anthropophilic infections tend to become highly chronic. They last for years and years. They are notoriously difficult to completely eradicate because your body essentially tolerates their low-level presence.
Ah, so they are the polite house guest who sleeps on your couch for a decade and never leaves.
Exactly. That persistent, nagging athlete's foot that flares up every winter but never quite goes away completely. That is almost always an anthropophilic infection, usually Trichophyton rubrum.
Now compare that polite behavior to the zoophilic fungi. This is where we get back to Daryl and his puppy Delbert.
Zoophilic fungi, like Microsporum canis, which, despite the name, naturally lives on both dogs and cats, or Trichophyton verrucosum, which naturally lives on farm cattle. These organisms are highly adapted to animal immune systems, not ours.
So when they accidentally jump the species barrier to a human host,
They're incredibly rude guests. They don't know the chemical house rules of the human body. They secrete abundant enzymes and metabolic toxins that are wildly irritating to human tissues because they aren't adapted to hide from us.
and how does the human immune system react to that blatant chemical insult?
Violently. That is exactly why Daryl had a massively swollen lip filled with pustules. The host body sees this alien, poorly adapted fungus acting aggressively, sounds every alarm, and launches a massive, destructive, inflammatory attack using neutrophils and macrophages.
So clinically, it looks absolutely terrible on the skin. It looks way worse than the anthropophilic kind.
It looks terrible, yes, but the long-term prognosis is actually fantastic. Because your immune system is fighting back so incredibly hard, the body very often clears the infection entirely on its own, or at the very least, it responds incredibly quickly to topical therapy. It is generally self-limiting.
That is deeply counterintuitive at first glance. The uglier and more painful the rash, the faster the natural cure.
In the specific world of dermatophytes, yes, absolutely. Acute, highly purulent inflammation means the body is actively winning the war. Chronic, mild, dry scaling means the fungus is comfortable in winning.
And the third category, geophilic.
Geo meaning earth. These dermatophytes live naturally as saprophytes decomposing keratin debris in the soil. Microsporum gypsum is the classic board exam example here. If a landscaper or a gardener gets this from playing in the dirt, it behaves clinically exactly like the zoophilic ones. It is an accidental human infection, so the body doesn't recognize it, and it reacts with profound, angry inflammation.
Okay, so applying this clinically. If I see a patient present with a super angry, raised, pus-filled wingworm lesion, my first question should be,
Did you just buy a new puppy? Or do you work on a farm with cattle? You are actively hunting for an animal or soil source. Conversely, if I see a very mild, dry, highly scaly rash that the patient has ignored for 3 years, I'm looking for a human source. Gym locker rooms, shared family towels, that sort of thing.
that is a brilliant diagnostic framework. It really turns the clinical diagnosis into an active detective story.
It really does. It's mechanism-based reasoning at its best.
Okay, let's take a tour of the body. Section 4 covers the clinical presentations, collectively known as the tineas.
The naming convention here is very simple, mostly just Old Latin. You take the word tinea, which roughly means fungal infection, and you add the Latin anatomical name for the infected body part.
Let's start right at the top of the head. Tinea capitis, scalp ringworm.
This is a massive topic, especially if you are going into pediatrics. It is relatively rare in adults due to changes in sebum chemistry after puberty, but it is incredibly common in prepubertal kids. And we have to clearly distinguish exactly how the fungus attacks the hair shaft itself. There are 3 very specific patterns of microscopic invasion you need to know.
Let's do pattern 1, ectothrix invasion.
Ecto meaning outside. In this pattern, the fungal hyphae grow down into the follicle and literally coat the outside of the hair shaft with a thick sheath of spores. It actively destroys the protective outer cuticle of the hair.
Which specific bugs tend to do this?
Usually the Microsporum species, like the Microsporum canis we got from our puppy.
And there is a really cool old-school physical exam trick to diagnose the specific pattern right in the clinic room. You don't even need to send a sample to the microscope.
The Woods lamp. It is a handheld ultraviolet light. If you turn off the clinic lights and shine a Woods lamp directly on a scalp infected with an Ectothrix microsporum, the infected hair shafts will glow a bright fluorescent green or yellow-green color.
Why on earth does it glow? Is the fungus naturally radioactive?
No, it's metabolic chemistry. The fungus actively produces terratine and pabylites as it grows. These specific chemicals have the physical property of absorbing invisible UV light and instantly re-emitting it as visible green light. It is a beautiful, albeit eerie, clinical sight.
And it is highly diagnostic. If the hair glows under UV, it is definitively an Ectothrix infection.
Right. Which brings us to pattern 2, Endothrix's invasion.
Endo meaning inside.
Exactly. Here, the fungal hyphae completely bypass the outer cuticle and invade the interior core of the hair shaft. They eat the structural cortex from the inside out.
So if it completely hollows out the structural core, what physically happens to the hair strand?
It loses all of its tensile strength. It becomes incredibly brittle. As soon as the growing hair pushes up out of the follicle and hits the surface of the scalp, the friction causes it to snap completely off.
It breaks perfectly flush right at the scalp level.
Exactly. And clinically, this creates what we call black dot tinea capitis. Because if you look closely at the bald patch on the kid's head, you don't see long hairs, you just see these tiny black dots filling the pores. Those dots are simply the broken off hair stubs packed completely full of black fungal spores.
And the primary culprit behind black dot tinea.
Trichophyton tonsurans. This is incredibly high yield. Trichophyton tonsurans is currently the #1 primary cause of scalp ringworm in the United States. And it spreads rapidly from kid to kid, meaning it is an anthropophilic organism.
Does this one glow if I hit it with the Woods lamp?
No, that is the absolute key clinical differentiator for exams. Endothrix infections caused by Trichophyton completely lack those terratine metabolites, so they do not fluoresce under UV light.
Okay, so mental summary. Glow equals Ectothrix, usually Microsporum. No glow plus black dots equals Endothrix, usually Trichophyton.
You got it perfectly.
And what about the third pattern, Favus? This one always sounds so medieval to me.
It is a severe, chronic, and highly destructive form of the disease. Favus is specifically caused by an organism called Trichophyton schonleni. It presents as a chronic infection where the patient develops these thick, cup-shaped crusts called scutula, forming densely around the base of the hair follicles.
What exactly are scutula structurally?
They are dense, hardened mats of fungal mycelium mixed with dead epithelial debris and dried sebum. Clinically, they look like little yellowish sulfur cups firmly stuck to the scalp.
And what is the fungus doing inside the hair shaft itself during this?
It creates a unique pattern we call honeycomb tunneling. If you pull a hair out and look under the microscope, the inside of the hair shaft is full of linear air bubbles where the fungus has selectively eaten away tracts of the core but left other parts intact, resembling a honeycomb.
And I've always read in the text that it has a highly distinctive foul smell.
Yes, the classic description is a mousy odor, like an abandoned dirty mouse nest. And because the inflammation is so deep and chronic, if Favus is left untreated, it routinely leads to severe permanent scarring alopecia, meaning permanent, irreversible baldness.
That is awful. So key associations. Scutula crusts, honeycomb hair invasion, mousy smell. That equals Favus, caused by Trichophyton schonleni.
Correct. Okay, moving down the face to the beard area. Tinea barbae.
This one is almost universally zoophilic in origin. You typically see it in rural farmers getting Trichophyton verrucosum directly from their cattle. Because it's an animal strain and a human, it is highly, violently inflammatory. The patient develops big, boggy, extremely pus-filled nodules in the beard area. To an untrained eye, it looks exactly like a severe bacterial staph abscess, but it is entirely fungal.
Now for the most classic one, Tinea corporis. Classic body ringworm on the glarous or hairless skin.
This is the classic annular or ring-shaped lesion we discussed earlier. A raised, red, highly scaly border surrounding a flat, relatively clear center.
Let's talk about the biology of that ring shape. Why does the center clear up while the edges expand? I've always found the physics of that lesion fascinating.
The easiest way to conceptualize it is to think of a forest fire spreading through a dense woods. The fungal organism is the fire, and the rich keratin protein in your stratum corneum is the combustible fuel. The fire inevitably starts in one central microscopic spot where the spore landed. As the fungus rapidly consumes all the available keratin in that immediate central area, it literally runs out of food. It has to grow outward in a radial pattern to find fresh, unconsumed fuel.
So the raised red leading edge of the ring is the active fire front.
Exactly. The red scaly border is where the active fungal metabolism and the intense immune battle are happening right now. The flat clear center is the burnt out area where the keratin fuel is totally depleted, the fungus has died off or moved on, and the skin is slowly attempting to heal itself.
That makes perfect mechanistic sense. So practically, if you are a resident and you need to scrape this lesion with a scalpel to get a sample for a KOH prep,
You absolutely never scrape the clear center. There is virtually no living fungus left there. You will get a false negative. You must always firmly scrape the active, raised, scaly leading edge to capture the live hyphae.
excellent point. Moving on to tinea cruis.
Better known colloquially as jock itch. It affects the warm, moist skin folds of the groin and upper thighs. It is typically caused by Epidermophyton flocosum, or our polite guest, Trichophyton rubrum. It absolutely thrives on the trapped friction and moisture in that anatomical area.
And then we have tinea pedis, athlete's foot.
Statistically, this is the most prevalent fungal infection in the entire world. It primarily presents in two distinct ways. First, you have the interdigital or macerated type, usually occurring squarely between the fourth and fifth toes. The skin there becomes stark white, highly peeling, wet, and often splits open into painful fissures.
And the second presentation, the moccasin type.
Yes, the moccasin distribution. Imagine a patient wearing a low-cut moccasin shoe made entirely out of dry, thickened skin. This presentation causes a hyperkeratotic, incredibly dry, silvery, powdery scale that uniformly covers the entire sole and the lateral sides of the foot. It is very chronic, barely inflammatory, and is almost exclusively caused by our anthropophilic friend Trichophyton rubrum.
And finally, arguably the toughest one of all to manage clinically, tinea unguium, also called onychomycosis, fungal infection of the nails.
This is where the dermatophyte successfully invades the hard nail plate itself. Over years, the nail becomes markedly thickened, heavily discolored yellow or brown, totally opaque, and structurally brittle to the point where it just crumbles apart.
And who is the usual prime suspect here?
Trichophyton rubrum again. The polite guest gets into the nail bed and just quietly sets up camp for decades.
Why exactly is it so notoriously hard to treat nail infections? I see pharmaceutical ads for topical nail lacquers and treatments for this constantly.
The human nail is essentially a fortress within a fortress. It is an incredibly dense, thick slab of tightly packed keratin. Standard topical antifungal creams or lacquers simply cannot physically penetrate deep enough through that hard dorsal plate to reach and kill the active fungal elements living buried deep in the nail bed underneath. You almost universally require systemic, oral medication to cure it from the inside out via the blood supply to the nail matrix.
We will dive deep into those specific systemic drugs in just a minute, but there is one more vital clinical phenomena we have to cover before we leave the presentations: the dermatophytid reaction.
The dermatid reaction. This conceptually confuses so many medical students and terrifies patients.
Walk us through exactly what happens clinically.
Okay, imagine a patient comes into your clinic. They have a documented severe case of tinea pedis, really bad inflammatory athlete's foot. But today, their chief complaint isn't their feet. They are intensely complaining about a sudden outbreak of tiny, highly itchy, fluid-filled blisters erupting all over the sides of their fingers and the palms of their hands.
So logically, the patient assumes they aggressively scratched their itchy feet and physically seeded the live fungus onto their hands.
That is exactly what they think. It is what basic logic suggests. But here is the trick. If you take a scalpel and carefully scrape those first blisters on the fingers and do a KOH prep, there is absolutely no fungus to be found.
No fungus at all. So what is causing the severe blistering on the hands?
The blisters are entirely sterile. The lesions on the fingers are a secondary allergic reaction. What happens is that highly immunogenic fungal antigens from the active foot infection get absorbed into the local capillary bloodstream. They circulate systemically, travel to the hands, and trigger a massive localized type 4 delayed hypersensitivity response in the skin of the fingers.
So the body's immune system is actively attacking the healthy tissue of the hand because it falsely detects circulating fungal proteins and thinks the fungus is physically there.
Essentially, yes, it is an immunological echo of the primary infection happening miles away on the foot.
So mechanically, if I want to cure the blisters on the patient's hands,
You completely ignore the hands. You must aggressively treat the primary source on the feet.
That is just wild. You prescribe medication for the foot to magically fix the blisters on the hand.
Exactly. If you waste time putting standard antifungal cream directly on the finger blisters, it won't do a single thing because there are no living fungal cells there to kill. You eradicate the fungal source factor on the foot, the antigen stops pouring into the blood, and the yeated reaction on the hands spontaneously fades away.
Fascinating immunology. Okay, let's move into section 5. We are back in the pathology lab. We need to definitively identify these dermatophyte invaders under the microscope. We previously discussed the three kings, Microsporum, Trichophyton, and Epidermophyton. Now, if you grow them on an agar plate, they all basically look like generic fuzzy mold. How do we visually tell them apart using microscopy?
It entirely comes down to the structural morphology of their conidia, which are their asexual reproductive spores. Specifically, we evaluate the presence, the shape, and the ratio of macroconidia, meaning the large multicellular spores, versus microconidia, the tiny single-celled spores. That specific ratio instantly tells you the genus.
Let's start with Microsporum.
The name Microsporum is a deliberate, cruel trick designed to fail medical students. Despite the prefix micro, Microsporum is actually characterized by having huge, highly abundant macroconidia.
So Microsporum equals macro.
Yes. Think to yourself, Microsporum is macro. These dominant macroconidia are very large, they have thick outer walls, their surface is notably rough or achnellate, and they are distinctly spindle-shaped, tapering at both ends.
The classic visual analogy is a rough, prickly football.
Exactly like a prickly American football. If you see a field full of prickly footballs under the scope, it is Microsporum.
And what about its microconidia?
They are exceedingly rare or entirely absent. You almost exclusively see big footballs.
Okay, next genus, Trichophyton.
Trichophyton is the exact morphological opposite. Trichophyton species produce absolutely massive quantities of tiny microconidia. In this genus, the large macroconidia are incredibly rare, thin-walled, or completely absent.
So Trichophyton equals tiny spores.
Right. And going a step further, the specific physical arrangement of those tiny microconidia along the hyphae tells you exactly which species you are looking at. Take Trichophyton rubrum, for instance. Its microconidia are classically teardrop-shaped, and they attach directly along the straight, parallel sides of the main hyphal strands.
The textbook notes always describe this arrangement as birds on a wire.
That is the universally accepted classic description. Little teardrop shapes sitting neatly in a row on the fungal strand, looking exactly like a flock of birds resting on a telephone wire. Also, as a quick bonus fact, T. rubrum colonies famously produce a deep blood-red pigment on the reverse side of the agar plate. Now, contrast that with Trichophyton mentagrophytes. Its microconidia are totally different. They clump tightly together in dense, round clusters, like tight bunches of grapes. And right next to those grapes, you will very frequently observe unique, tightly coiled, spring-like hyphal structures called spiral hyphae.
Okay, so birds on a wire equals T. rubrum. Bunches of grapes plus spiral springs equals T. mentagrophytes. Got it.
And finally, we have the third king, Epidermophyton.
The one that spares the hair.
Exactly. Epidermophyton is the ultimate Goldilocks of the group. Under the microscope, it has absolutely zero microconidia. None. It only produces macroconidia. But these macroconidia look entirely different from the rough footballs of Microsporum.
How so? What is the visual?
They are completely smooth-walled, they are broadly club-shaped, and they are rounded at the distal end. We formally call this shape beaver tails.
Beaver tails. That is an incredibly vivid image.
And another key feature is that these smooth beaver tails strongly tend to cluster together at the ends of hyphae in specific groups of 2 or 3. So if you look down the lens and see smooth beaver tails hanging in small clusters and a total strict absence of any tiny microconidia, your diagnosis is unequivocally Epidermophyton.
So let's do a rapid recap for the listeners taking notes.
Look for the rough, prickly footballs, meaning abundant macroconidia.
Look for the smooth beaver tails in clusters with zero microconidia.
Look for the tiny microconidia either arranged as birds on a wire for rubrum or clustered as grapes for mentagrophytes.
That is the ultimate diagnostic key. You can accurately identify any board exam slide instantly if you apply that simple structural framework.
Awesome. Now let's move to section 6, treatment principles. We've hinted heavily at this throughout, but let's formally consolidate it.
The foundational principle of treating any superficial or cutaneous mycosis is entirely about anatomical location.
Okay, what if the infection is strictly limited to the glabrous skin? Things like tinea corporis, tinea curis, or a mild tinea pedis?
For uncomplicated skin infections, topical therapies work brilliantly. Use over-the-counter or prescription creams containing azole derivatives like clotrimazole or miconazole or allylamines like terbinafine, which is sold as Lamisil. The stratum corneum is relatively thin enough for the drug vehicle to absorb deeply, reach the active fungal hyphae, and inhibit their ergosterol synthesis, killing them.
But what if the infection is firmly entrenched in the hair follicles or deep within the nail plates?
That changes the game entirely. You almost always require systemic oral therapy, pills. As we discussed, topical creams simply cannot physically penetrate the deep hair follicle root or diffuse through the dense, thick keratin of the nail plate effectively enough to clear the deeply buried infection. If you try topicals for those, you will face nearly a 100% relapse rate.
So for a severe tinea capitis on a child's scalp or a stubborn onychomycosis in an adult's toenails, we prescribe pills.
Yes, systemic therapy is mandatory. Historically, grisafulvin was the absolute gold standard, especially for pediatric scalp ringworm. Grisafulvin is a fascinating older drug. It doesn't target the fungal cell wall. It actively binds to the fungal microtubules internally, physically disrupting the mitotic spindle and arresting fungal cell division. It stops them from multiplying. But the coolest part is its pharmacokinetics. It physically binds to the newly synthesizing keratin deep in the precursor cells.
So as the new hair shaft grows out from the root, it emerges completely preloaded with the drug, making it essentially fungus-proof.
Exactly. It slowly pushes the active infection out as the hair grows. But nowadays, particularly for nail infections, which are notoriously stubborn, we lean heavily toward newer oral drugs like terbinafine or itraconazole. Oral terbinafine is highly fungicidal, meaning it directly kills the fungus rather than just pausing it, and it heavily accumulates and concentrates directly in the keratin of the nails. It actually stays functionally active in the nail tissue for months, even after the patient finishes swallowing the last pill.
But because it relies on the slow process of nail growth, it still takes a very long time to see the final clinical result.
Very long. Often 3 to 6 months for a fingernail, and easily 9 to 12 months for a large toenail to entirely grow out clear. You have to aggressively manage patient expectations, or they will assume the drug failed after 4 weeks and just stop taking it.
All right. We have thoroughly covered the fortress wall, the stealthy graffiti artists, the invasive battering rams, the polite versus rude evolutionary guests, and the microscopic beaver tails. I really think I've got a solid handle on this entire chapter.
You think you're genuinely ready to put it to the test?
I think so, but I definitely want to test it. I'm going to throw some rapid-fire case scenarios at you, things I might reasonably see in a clinic or on a board exam, and I want to see if I can logically figure them out myself based on what we've covered. You jump in and correct me if my reasoning is flawed.
I love this. Let's do a rapid SBA case review. Fire away.
Case number 1. I've got a 22-year-old male patient. He just got back from a sunny spring break trip. He's got these noticeable hypopigmented light patches scattered across his upper chest and back that completely fail to tan in the sun. I do a quick scraping, look under the scope, and I clearly see the classic spaghetti and meatballs pattern. I know internally it's Malassezia, but I want to actively grow it in the lab to definitively prove it. What specific instruction do I need to give the lab tech regarding the agar plate?
Oh, testing the foodie knowledge right out of the gate. Do you remember what you have to feed it?
It's the olive oil overlay, right?
Correct. You must add olive oil or any source of long-chain fatty acids.
And the specific clinical insight here, Malassezia furfur is a strictly lipophilic yeast. It lacks the biological machinery to synthesize its own lipids. Without that specific oil overlay on the agar, the culture plate will remain completely empty, leading to a false negative. For consolidation, students should review the pityriasis versicolor section in Murray Chapter 62.
Spot on reasoning. Hit me with the next one.
Case number 2. A 6-year-old boy is brought in by his mother. He has a highly noticeable circular bald patch on his scalp with severe scaling. The mother is very worried. I turn off the clinic lights and shine a handheld woods lamp directly onto the bald patch. The remaining broken hair shafts clearly fluoresce a bright, glowing green. My primary diagnosis is a Microsporum species.
Yes, highly likely to be Microsporum canis, especially if they have a pet.
And the mechanistic insight. The bright green fluorescence confirms an ectothrix pattern of infection. The fungus is actively growing on the outside of the hair shaft and actively secreting those glowing pteridine metabolites. If it were the most common U.S. cause, Trichophyton tonsurans, it would be an endothrix infection, and it would absolutely not glow.
Perfect differentiation. For review, check out Table 62.2 in Murray. Number 3.
Case number 3. I'm staring down the barrel of a microscope looking at a fungal culture slide. I clearly see these large, completely smooth-walled, club-shaped macroconidia. They look exactly like little beaver tails, and they are attached in tight clusters of 2 or 3 at the ends of the hyphae. I diligently scan the rest of the slide looking for tiny microconidia, but there are absolutely 0 to be found. It's got to be the genus Epidermophyton, right?
Spot on again, specifically Epidermophyton floccusum.
And the visual insight. It's the Goldilocks morphology rule. Smooth beaver tail clubs representing the macroconidia, paired with the highly specific absolute absence of any microconidia, instantly distinguishes Epidermophyton from both Microsporum and Trichophyton. Students can lock this down by reviewing the morphology section of Murray, chapter 62.
Absolutely correct. Next case.
Case number 4. This is the clinically scary one. A patient presents with a totally flat, very dark black, highly irregular macule located right on the palm of their left hand. The patient is terrified, and frankly, my first instinct is that it looks exactly like an acral lentiginous melanoma. I do a quick KOH prep in the office, and I see pigmented, dark brown hyphae. I get to tell them the great news that it's not cancer, it's just a superficial fungus called tinea nigra.
You saved the day and a lot of surgical morbidity.
Mhm.
Tinea nigra.
And the biological insight. It is caused by the demycetious fungus Hortea wernicki. It is a completely benign, totally superficial infection where the organism naturally produces dark melanin pigment in its cell walls, perfectly mimicking a lethal melanoma lesion but causing no actual tissue invasion. Review the tinea nigra section in Murray for the details on that.
Excellent clinical catch. Give me number 5.
Case number 5. This one tests the prognosis concepts. I have 2 different patients sitting in rooms next to each other. Patient A has a super angry, highly inflamed, pus-filled ringworm lesion on his forearm. Patient B has a very mild, slightly itchy, incredibly dry, scaly patch on his foot that he admits he's had for about 3 years. Based on ecology, which patient is going to be significantly harder to ultimately cure?
Oh, this is a fantastic board-style setup.
Yeah.
Basic instinct says the angry, pus-filled one is the worst disease.
Right, but based on the host-guest evolutionary model, I'm going to strongly argue that patient B, the one with the mild, chronic, dry patch, is the real therapeutic problem. That represents an anthropophilic infection.
You completely nailed it. Anthropophilic infections, like T. rubrum, are highly chronic and notoriously difficult to cure entirely because the human host's immune system essentially tolerates them. They're the polite guest. The angry, purulent zoophilic rash on patient A is currently being viciously attacked by the host's immune system and will very likely clear up quickly with minimal intervention. Review the ecology and epidemiology section in Murray to master that concept.
Perfect. Case number 6. Last one. Remember that guy with the severe chronic athlete's foot? Tinea pedis. He comes back to the clinic 2 weeks later because he has developed an outbreak of highly itchy, fluid-filled blisters all over his fingers. I take a scalpel and scrape the fluid and the roof of the finger blisters. What specific fungal elements do I see under the microscope?
What do you see?
I see absolutely nothing.
Correct. Nothing at all. It's completely sterile.
And the immunological insight. This is the classic dermatophyted or id reaction. It is a systemic delayed hypersensitivity response to circulating fungal antigens from the primary foot infection, not a local fungal infection of the hands. You must treat the feet to cure the hands. This specific nuance is detailed beautifully in the Jowett's Chapter 45 supplement under the Trichophytid reaction section.
Fantastic job. I honestly feel like you actually understand the deep why behind these presentations now, not just the rote memorization facts.
I really do. It all comes back to the core framework. We have the superficials, which are purely cosmetic with zero immune response. And we have the cutaneous dermatophytes, which actively eat keratin and trigger intense immune battles. And you always have to ask yourself if the guest causing the problem is polite, meaning human adapted, or rude, meaning animal adapted.
Exactly. You master that. You master the topic.
Now, before we sign off, I want to leave our listeners with a final, somewhat provocative thought to mull over. We repeatedly emphasize that dermatophytes are strictly thermophobic. They are completely confined to the outer skin because they simply cannot survive our internal core body heat of 37 degrees Celsius. That thermal barrier is essentially our main evolutionary biological defense against them becoming deeply invasive systemic killers.
Right. They literally burn up and die if they
Yeah.
try to enter our bloodstream.
Well, look at the world right now. The globe is undeniably getting hotter. Climate change is steadily raising ambient environmental temperatures everywhere. We are already seeing once obscure environmental fungi, like Candida auris, rapidly emerge as multi-drug resistant, highly thermotolerant systemic killers in ICUs worldwide.
It raises a deeply unsettling yet scientifically valid question. If these superficial fungi like the geophilic and zoophilic dermatophytes that currently live in soil and on animals, if they are forced by climate pressure to gradually adapt to much higher ambient environmental temperatures just to survive outside, will they eventually cross that critical thermal barrier of the human body?
Meaning, if they learn to thrive at 37 degrees in the environment, our core temperature is no longer a defense mechanism.
Exactly. Could the highly annoying but fundamentally harmless ringworm of today slowly evolve into an aggressive, tissue-destroying, invasive systemic pathogen of tomorrow? What happens when a keratin-eating battering ram learned how to survive inside your deeply vascularized tissues?
That is a genuinely terrifying thought to leave on, going from a cosmetic graffiti artist or a surface nuisance to a literal internal assassin simply by cranking up the global thermostat.
When you are studying fungal evolution and the sheer adaptability of these organisms, you really learn to never say never.
Well, on that profoundly cheerful and apocalyptic note, I think we'll wrap it up. Keep your skin dry. Definitely don't share your towels or combs at the gym. And please be exceedingly careful who you smooch, especially if they happen to be a bulldog puppy named Delbert. Thank you for joining us on this deep dive.
See you next time.